We will talk about chronic obstructive pulmonary disease, also called COPD, how and why it develops, the top 7 signs and symptoms, and how to treat and prevent it. The primary feature of chronic obstructive pulmonary disease is irreversible airflow limitation in the bronchi, meaning the person has difficulty fully exhaling. This happens due to inflammation and damage in the bronchi and lungs. COPD is a significant global challenge affecting 10% of the population over the age of 40 and ranking as the 3rd leading cause of death worldwide. Shortness of breath is the most important symptom of COPD. It means the person feels out of breath, especially during physical activity. Over time, it becomes more severe and can occur even at rest. The second symptom is a cough. The cough is typically more prominent in the mornings and is frequent. Patients also report mucus production during coughing. Sputum production is common in the mornings and can vary in color from white to yellow or greenish, depending on infection. Wheezing is the 3rd important symptom. It is a high-pitched, whistling sound that occurs during breathing, especially when exhaling. This happens due to narrowed airways, and people describe it as noisy breathing. This noise is usually noticeable to the patient themselves. If others can hear the breathing noise, it means the obstruction is already serious and significant. People with COPD experience frequent infections and often say they are always catching colds or respiratory bugs. Tiredness is also common because the lack of oxygen causes feelings of fatigue. Symptoms worsen gradually over the years. Initially, the patient may notice breathlessness with intense activities, such as climbing stairs. Morning cough and mucus production are hallmarks of the condition and are commonly described by patients. COPD is different from asthma. In COPD, the symptoms are not reversible. While patients may experience episodes of severe symptoms followed by improvements, the baseline symptoms such as coughing and difficulty breathing during exertion remain. This is a hallmark of the condition. The symptoms remain stable but worsen over time. People with COPD are usually smokers or have a history of long-term exposure to pollutants, such as occupational dust or fumes. Their cough typically lasts for at least 3 months or more and over at least 2 consecutive years. COPD has 2 main forms. The first is the bronchial form, which is called chronic bronchitis. This usually causes a chronic productive cough and difficulty clearing mucus. People with chronic bronchitis often suffer from repeated infections like bronchitis or pneumonia. They also experience shortness of breath, which worsens over time but often starts with a heavy cough and mucus production. The second form is the emphysematous form, called emphysema. This type involves damage to the alveoli, the small air sacs in the lungs, leading to poor gas exchange. It causes hyperinflation of the lungs and breathlessness. The most important symptom of emphysema is shortness of breath, which gradually worsens. The second sign is pursed lip breathing, meaning the patient exhales as if blowing out a candle through slightly pursed lips. Barrel chest is another sign of emphysema. When the lungs become hyperinflated, the chest takes on a rounded shape. Patients mostly complain of shortness of breath, which progressively worsens. They might not cough much, and when they do, it is usually dry. These 2 diseases are united under the term COPD because the mechanism is the same. In both cases, there is airflow limitation. Both are associated with smoking and lung irritants. Both are progressive and irreversible. Almost 85% of COPD is associated with smoking. Around 10% with occupational pollution. Small amount because of outdoor pollution. And only 2% is because of genetics. Patients often have mixed symptoms because people with chronic bronchitis may develop emphysema and vice versa. For example, a patient may have both the cough and mucus production of chronic bronchitis and the shortness of breath of emphysema. Treatment approaches. The management for both chronic bronchitis and emphysema is similar. If COPD is left untreated, several important complications occur, including frequent infections, worsening breathing, and increased blood pressure in the lungs, which is called pulmonary hypertension, and eventually right-sided heart failure due to pulmonary hypertension called cor pulmonale can occur. It causes swelling in the legs, edema, abdominal swelling, and difficulty breathing at rest. Heart failure and respiratory failure are common causes of death in patients with untreated chronic bronchitis. COPD also increases the risk of lung cancers, especially in smokers. To diagnose COPD, the ratio of forced expiratory volume in 1 second to forced vital capacity should be less than 70% after using bronchodilators. In young, healthy adults, this ratio should be more than 80 to 85%. Unfortunately, COPD is a progressive disease and there is no cure. However, slowing down the progression is possible. If a person has mild COPD with proper management, they can live almost a normal lifespan. In cases of moderate COPD with proper management, it is possible to live for 10 to 20 years. In cases of severe COPD, even with proper management, patients typically live around 5 to 10 years. In very severe cases, life expectancy is even shorter. The first-line treatment for COPD is bronchodilators. These are usually in inhaler form for fast and targeted action. Examples include albuterol, also known as salbutamol, and ipratropium. They provide immediate relief of symptoms. Long-acting bronchodilators called LABA, such as tiotropium, aclidinium, and formoterol, are also used. While fast-acting inhalers are used during exacerbations or episodes of difficulty breathing, these long-acting medications are used as maintenance therapy. The second-line treatment is inhaled corticosteroids, such as fluticasone and benbucicide. These are often combined with long-acting bronchodilators. They are used in more moderate to severe COPD to help reduce inflammation and the frequency of exacerbations. Severe and very severe COPD require more complex therapy, and oxygen therapy can be life-saving in severe cases. Pulmonary rehabilitation is essential. It is a program that includes exercise training, education, and breathing techniques to improve lung function, reduce symptoms, and increase physical stamina. Smoking cessation is also necessary if the person is a smoker. It prevents the progression of the disease and improves lifespan. Annual flu vaccination and pneumococcal vaccines are recommended to prevent respiratory infections. In severe cases, surgery, such as lung volume reduction or lung transplantation, may be considered in end-stage COPD when other treatments fail. Regarding supplements, omega-3 fatty acids help reduce inflammation and improve overall health. The recommended dose is usually 1,000 milligrams for long-term use. Vitamin D is important because patients with COPD commonly have vitamin D deficiency. Vitamin D improves immune system function. Lifelong supplementation may be needed, especially in COPD patients who are often vitamin D deficient. Common doses are 1,000 to 2,000 IU daily. Antioxidants like N-acetylcysteine are strong antioxidants that help in mucus and improve lung function. Typical doses are 600 to 1,200 milligrams per day, often divided into 2 doses. It is usually taken long term. Magnesium also improves lung function in patients with asthma and COPD. Magnesium helps relax the airways. Coenzyme Q10 can also help reduce inflammation and improve cellular energy production.